Good evening, everyone. I'm audible and visible to all of you guys. Just update me in the comment section. Good evening, everyone. I'm audible and visible to all of you guys. Just write down in the comment section if I'm audible and visible so that we can proceed with the session. Hello. Okay, fine. Thank you. Okay, so good evening, guys. Today we are going to have a crisp and concise session on the chapter abortion, and followed by that, we have already uploaded that we are going to start a full 19 subject rapid revision session on the Meduhub app from 2nd of June onwards. Okay, now before proceeding this session, we'll have an integrated session. We'll be discussing all the PYQs that have been asked from this particular chapter, and in the end we'll conclude the chapter with the most frequently asked question about the medical termination of the pregnancy. Okay, and meanwhile, whatever you know about this particular chapter, okay, all the things you guys can write down in the comment section. Now, this is the rapid revision session, guys. We'll not go in a much detail, but we'll focus on the high content that has been asked repeatedly in your exams. Okay, now before starting the abortion, let's discuss first what exactly is the definition of an abortion. What exactly is the definition of abortion? Now, if we talk about an abortion, it means the spontaneous pregnancy loss, or we can say the induced termination of the pregnancy. Now, what do I mean by the two words? One, I've discussed that spontaneous. So either the abortion can be spontaneous, or the abortion can be the induced, or the abortion can be induced. Spontaneous abortion describes our missed abortion, complete abortion, incomplete abortion, inevitable abortion, or threatened abortion. That will be termed under the spontaneous abortion. What is induced abortion? Induced abortion is something we go with the medical termination of the pregnancy with the help of medicines or the drugs. Okay, that is an induced termination of pregnancy. Now, if we talk about the WHO definition of the abortion, as per the WHO, the abortion is defined as the pregnancy loss. So, as per the WHO, it is defined as pregnancy loss less than 20 weeks. The pregnancy loss less than 20 weeks or before the 20 weeks, or if the fetal weight is if the fetal weight is less than 500 grams. If the fetal weight is less than 500 grams. Clear to everyone? Now, sir, if we talk about around 20 weeks of pregnancy, the weight of the fetus is somehow between 320 to 350 grams. Okay, as per the 20 weeks pregnancy. Okay, now if it is more than 20 weeks, now if this pregnancy it's more than 20 weeks, or if the pregnancy is more than 500 grams, then it's defined as intrauterine fetal demise. So it's then defined as intrauterine fetal demise. Okay, now if we talk about the basic definition of abortion, again, so abortion means the induced or the spontaneous loss of the pregnancy. Okay, spontaneous matlab, spontaneous will have complete abortion, we have incomplete abortion, we have threatened abortion, Okay, we have inevitable abortion. These are all the spontaneous abortion. Okay, number one. Number second is induced abortion. Induced abortion बच्चे किसको बोलेंगे? So induced abortion is something which is due to, with the help which we induce with the help of medicines, or we can go for the surgical procedure for the abortion. Okay, third one we have a recurrent abortion. We call it as recurrent pregnancy loss. क्या बोलेंगे उसको? Recurrent pregnancy loss. That I will discuss in a while. Okay, what exactly is recurrent pregnancy loss? Or बच्चे we have early pregnancy loss. Okay, so we have one more called as early pregnancy loss, when the pregnancy is lost before the 12 weeks. Okay, before the 12 weeks, or I will discuss early pregnancy loss before 12 weeks, or the crown rump length is around 5 mm. That is termed as an early pregnancy loss. Now all these definitions are clear. Spontaneous abortion, induced abortion, early pregnancy loss, recurrent pregnancy loss. Now we will be discussing all these things in a detail. Okay, what are the types, what will be the presentation of the patient, and what are the causes of this particular abortion. Okay, now if we discuss about two main types of abortion, we have either embryonic abortion, sir. एक तो हमारे पास कौन सा होता है? We have embryonic abortion and we have an embryonic abortion. We have embryonic abortion and we have an embryonic abortion. Okay, now speed is okay, guys? Please let me know in the comment section. Speed is fine, as this is a rapid revision session, so that we can go a bit faster. Yes? Okay, good. Now, so what is embryonic abortion? Now, if we discuss what exactly is embryonic abortion is simple, in which embryo is there. Okay, so you can write it down. It's a type of abortion. So this is a type of abortion / embryo is present. It's a type of an abortion, embryo is present, and there is no cardiac activity, and the crown rump length is equal to or more than 7 mm. This you will remember. The crown rump length is equal to or more than 7 mm. That is going to be embryonic abortion. Okay, what are the types of embryonic abortions? All the spontaneous ones. We have threatened abortion, we have inevitable, we have complete, incomplete, missed abortion. These are embryonic abortion because the embryo is there, embryo is present. What is an embryonic abortion? Sir, an embryonic abortion, it's also known as blighted ovum. क्या बोलते हैं इसको बच्चे? और sir, it's also known as blighted ovum. First thing. Number second thing, the embryo is absent. Embryo is absent. Okay, and there is a gestational sac. Yes, all clear? All clear? Yes, there is a gestational sac of more than 25 mm. Gestational sac more than 25 mm. Okay, now what exactly happens in case of an embryonic abortions? Sir, in embryonic abortions, fertilization does take place, but later on it does not develop into the embryo. That's why it's called as an embryonic abortion. Okay, there is no yolk sac or fetal pole. There is no yolk sac or fetal pole. There is no yolk sac or fetal pole. Okay, now my dear students, I have one question for you guys. Okay, as this is a rapid revision session, you might have gone through your primary notes and we have already discussed in the class. Can you tell me about which type of abortion has a presentation same like a blighted ovum or an embryonic abortion? Which type of spontaneous abortion has a presentation same like the blighted ovum or an embryonic abortion? Anyone in the comment section, please? The only difference will be there, embryo is formed in that type of abortion, that is an embryonic abortion, and embryo is not formed in the blighted ovum. Rest they will be same. Anyone in the comment section? It's usually a missed abortion. Okay, missed abortion में क्या होता है? Same presentation, like a spotting a bit. Okay, but the only difference is the yolk sac, no fetal pole in case of an embryonic abortion, but वहाँ पे fetal pole or yolk sac present होता है. Okay, now what can be the causes of the abortion? Okay, now depending upon the trimester, in the first trimester we usually have which type of causes? Chromosomal causes. Okay, in second type, usually in the second trimester we have the causes like anatomical causes. Now we'll discuss what are the chromosomal causes of abortion and what are the anatomical causes of an abortion. Clear to everyone? Now if we talk about the chromosomal causes of abortion, sir, these chromosomal causes are usually present, so they are usually present in first trimester. They are usually present in the first trimester. Okay, like what are the causes? We have trisomies 16, 18, 21, and we have monosomy 45. It's Turner syndrome. So usually in the first trimester, if they ask the question, the most common cause of a first trimester abortion is, your answer is going to be chromosomal type of abortion. Your answer is going to be chromosomal cause for the abortion. Clear to everyone? Yes. Now sir, if we talk about the anatomical causes, now you already know that. Tell me, all the female genital structures are developed from which duct? All the female genital structures or the female genital structures are developed from which duct? Female genital structures are developed from which duct? Yes, female genital structures are developed from which duct? Yes sir, they are developed from Mullerian duct. Very good. They are developed from Mullerian duct. So can I say any defect in the Mullerian duct, the genital structures that are coming from there? For example, uterus is coming from there. If I say that any defect in the Mullerian duct will result in the defect of an uterus. And what are the uterine defects, you know, if they are the congenital? So number one is going to be septate uterus. Number one is going to be septate uterus. Okay, these are all the congenital defects. These are all the congenital defects. Number second one is going to be the bicornuate uterus. Number second is bicornuate uterus. Okay, now these are the defects which are what? Congenital. Okay, either these defects are arising from the fusion, from the abnormal fusion of the Mullerian duct. Okay, now we have vertical fusion defects and we have vertical fusion defects. Usually we have septate uterus, bicornuate uterus. Okay, and all these defects are present from the beginning only. Okay, now if later on a patient can have an acquired defect, what can be the acquired defect? Due to some surgery for the cervix, due to some surgery. Okay, the defect that can be acquired is in cervical insufficiency or cervical incompetence. So that's cervical incompetence or cervical insufficiency. Now this cervical incompetence or this cervical insufficiency can also be either present congenital or it can be present afterwards. Okay, congenital, weak tissues over there. Okay, or after that, if in case a patient is going for the surgery for the cervix, patient can also develop cervical insufficiency. What is cervical insufficiency? When the length of cervix is how much? Less than 2.5 centimeter or less than 25 mm. Is that clear? So one question can be asked that a patient had a second trimester abortion, and second trimester abortion, you already know, can be related to the anatomical cause, and which of the following indicates the cervical insufficiency? Okay, now if the question is like this, bache, a 25-year-old gravida 2 abortion 1 at 18 weeks of gestation, she came with the complaints of draining per vaginal for past 4 hours. On examination, membranes are ruptured and uterine contractions are present. Which of the following sonographic findings is indicative of cervical incompetence in this patient? Update me in the comment section, bache. What can be the answer for this particular question? If a female is there and she is having one abortion only before and she is a gravida 2, there is a rupture and the uterine contractions present. Which of the following findings is an indicative of a cervical incompetence? Out of which of the following finding is an indicative of cervical incompetence? Out of which of the following findings will be the indicative of cervical incompetence? What will be the answer? Yes, everyone. How can the answer be B? B is more than 35 mm. I just discussed that cervical insufficiency or cervical incompetence means a short cervix, and short cervix is less than 2.5 centimeter. And if we convert 2.5 centimeter into the mm, it's going to be less than 25 mm. So what will be the answer? Answer is going to be option C. Answer is going to be option C. Clear, bache? Okay. Chalo, next. Next. Now, sir, what can be the possible? Is that clear to everyone? So remember, less than 2.5 centimeter, less than 2.5 centimeter, or less than 25 mm. This is the case of an cervical insufficiency. Now, what are the possible treatments? Okay, we'll discuss in a while how we can treat a patient with a septate uterus, how we can treat a patient with a bicornuate uterus, and how we can treat the patient with a cervical insufficiency. Okay, now if we discuss about the maternal causes, now these maternal causes which can be present during any of the trimester. The maternal causes can be present during any of the trimester. Okay, now what can be the maternal causes? First of all, the maternal causes like torch infections, toxoplasmosis, other, rubella, CMV, and herpes. Okay, torch infections. Okay, followed by that, patient can have an acquired thrombophilia. What is a thrombophilia? It's a condition which predisposes to the formation of the clots in the body. Now, these thrombophilias can either be congenital, present from the beginning only, or either they can be acquired. And APLA is an antiphospholipid antibody syndrome. It's a type of an acquired thrombophilia. Okay, this can also cause an abortion. Followed by that, patient having diabetes, followed by patient having hypothyroidism. All these conditions, if not controlled, they can cause an abortion. Cancers or syphilis. These are all the maternal causes of abortion, bache. These are all the maternal causes of abortion. So in a first trimester, we have chromosomal. We have 16, 18, and 21 or 45. That's Turner syndrome. Okay. Followed by that, we can have an anatomical cause. So what is an anatomical cause? Anything related to the anatomy. And we all know that female genital structures are coming from which duct? They are coming from a Mullerian duct. And the most common Mullerian defect, if they ask the question, most common Mullerian defect, what will be your answer? Write down in the comment section. From the anat, if they ask that what is the most common Mullerian defect, let me know. What is the most common Mullerian defect? Your answer goes to septate uterus. Your answer goes to septate uterus. Okay. Chalo. Your answer goes to septate uterus. Next is going to be the bicornate uterus. Either there will be a cervical incompetence or the short cervix, also called as cervical insufficiency. How to define this? When the cervix is less than 2.5 centimeter or less than 25 mm, that is cervical incompetence. Okay. Now, sir, what exactly is a recurrent abortion? As before the beginning of this session, I've told you, either there will be spontaneous abortion, ya to induced abortion, or ya to recurrent abortion. Now, if we talk about the recurrent abortion, how to define the recurrent abortion? It means 3 or more than 3 recurrent abortions. It's also called as habitual abortion. और क्या बोलते हैं इसको? Sir, it's also called as habitual abortion. And it's more in which trimester? It's more in second trimester. These abortions, they are usually more in which trimester? They are usually more in the second trimester. The most common group of cause is going to be endocrinopathies. Now, related to the endocrinology, what can be the possible causes? So, related to the endocrinology, patient can have diabetes, patient can have hypothyroidism, patient can have PCOS, because if they ask most common endocrinological disorder in females is reproductive females is PCOS. Okay, PCOS is also related to the endocrinopathies. Okay, so we have diabetes, we have thyroid, we have PCOS. These are all the endocrinopathies related to the recurrent abortion. Okay, now most common cause of second trimester pregnancy loss. Now we already know second trimester pregnancy loss, usually we have which causes? So we have uterine causes. So we have uterine causes. And if examiner will ask first trimester, in first trimester usually the cause for a recurrent abortion is APLA, that is antiphospholipid antibody syndrome. That is antiphospholipid antibody syndrome. Clear to everyone? Clear to everyone, bacha? Yes, that's going to be antiphospholipid antibody syndrome. Now, what is recurrent abortion? 3 or more than 3 pregnancies. So, overall, the more common cause is going to be endocrinopathies, diabetes, thyroid, PCOS. Okay, PCOS is also related to the endocrinology because it is an insulin resistance. Hai na? Then followed by that in second trimester, so the uterine causes, something wrong with the uterus. So most common cause of first trimester recurrent pregnancy loss, it's going to be antiphospholipid antibody syndrome. It's going to be antiphospholipid antibody syndrome. Okay, now let's discuss about the anatomical causes of abortion and the management of these causes. Now let's discuss what are the anatomical causes and the management of these causes. Okay, now as we discussed that there are 3 anatomical causes. These related to the anatomy, there are 3 things. Either so the septate uterus, usually bicornate uterus, or the cervical incompetence or cervical insufficiency. Clear? Now if we talk about the first, that's going to be septate uterus. One thing you will remember about the septate uterus is it's the most common Mullerian defect. Sir, it's the most common Mullerian defect. Okay. Second, it's the most common cause. It's the most common cause. Which cause? Uterine cause. It's the most common uterine cause of recurrent pregnancy loss. It's the most common uterine cause of recurrent pregnancy loss. What is RPL? Recurrent pregnancy loss. And it usually causes second trimester abortion. it usually causes second trimester abortion. And if the question will be asked, what is the management for the septate uterus, bache? Sir, this is a septate uterus, okay, there is a septa in between, and we are going hysteroscopically and resection of this septa, okay, and this is called as hysteroscopic resection, okay. Normal uterus will make by resecting this part. So if simple question will be asked, what is the management of a patient having a septate uterus, your answer should be hysteroscopic resection. What will be your answer, bache? Your answer will be hysteroscopic resection. That's a treatment for the septate uterus. That's a treatment for septate uterus. Clear to everyone? Is that clear to everyone? Yes? Good. Now second one is going to be bicornuate uterus. So what is bicornuate uterus? There are two horns. Can you see? There are two horns present, okay, and this is called as bicornuate uterus, okay. So write it down. So this bicornuate uterus, it also causes second trimester abortion related to the anatomy, okay. Now there are two horns present. Now what we will do, we'll do a surgery called as Stressman metroplasty. It's a procedure that will unify these two horns and make a single cavity, okay. Now what is the name of the surgery? What will be the management? So it's called as Stressman metroplasty, also called as unification surgery. So also called as unification surgery. Now what is bicornuate uterus? It's a congenital defect in which the uterus has two horns, okay. ये two horns क्यों होते हैं? Because of an incomplete fusion of the Mullerian duct. Because of incomplete fusion of Mullerian duct. As I've already told you, female structures कहाँ से आते हैं? Mullerian duct. Male structures Wolffian duct, okay. Now due to the abnormal or due to the incomplete fusion of this duct, so we have a bicornuate uterus having two horns, and this bicornuate uterus while having two horns, we are going for this bicornuate uterus having two horns. We are going for a procedure called as Stressman metroplasty. We are going for a procedure called as Stressman metroplasty. Is that clear? Now this is called as Stressman metroplasty, okay. Now next is going to be the incompetent os. Next one is going to be incompetent os. And again, what is incompetent os? Sir, it means a short cervix, okay. When the length of a cervix is less than 2.5 centimeter, when the length of a cervix is less than 2.5 centimeter or less than 25 mm. When the length of the cervix is less than 2.5 centimeter or less than 25 mm. Is that clear? Yes. Now if we discuss about the short cervix, when the cervix is short, what will happen? It will predispose to the preterm labor or abortion, okay. Now write it down. So about an incompetent os, it will predispose to preterm labor. It will predispose to preterm labor and abortion. It will predispose to preterm labor and abortion, okay. Next, so if we talk about the presentation, let's write here. If we talk about the presentation of a patient having an incompetent os, first of all, how this patient will present having an incompetent os, write it down. So patient will give a history of, right, presentation. If we talk about the presentation, sir, the patient will give a history of recurrent preterm birth, or second trimester abortion. Patient will give a history of preterm birth and second trimester abortion. First thing. Second thing, in the presentation there will be a painless dilatation of the cervix. So there is painless cervical dilatation. There is painless cervical dilatation, followed by, when the cervix will be dilated, there will be the prolapse of the membranes, and followed by that there will be the expulsion of the fetus. Okay, that's why if it occurs around the preterm pregnancy, या तो preterm कराएगा. If it occurs prior to that, there will be eventually a second trimester abortion. So what is the classical presentation of a patient? Remember, in equation the examiner will mention the painless cervical dilatation, बच्चे, the painless cervical dilatation. And what exactly is painless cervical dilatation? So painless cervical dilatation means that there will be opening of the cervix, due to which क्या होगा? Prolapse of the membranes will be there. Okay, once the membranes will be prolapsed, followed by that there will be the expulsion of the fetus. Followed by that there will be the expulsion of fetus. So painless cervical dilatation followed by prolapse of membranes, and expulsion of fetus. Okay, so remember, this is going to be the presentation of a patient. This is going to be the presentation of a patient having incompetent os or the short cervix. It's also called as cervical insufficiency. It's also called as cervical insufficiency. Now what will be the management? Can you write down in the comment section? What will be the management? Anyone in the comment section, what will be the management? What will be the management, students? So the management for this particular condition is, अगर cervix खुल रहा है, if there is a painless dilatation of the cervix, so suture it. Okay, put a cerclage over there. Okay, and the cerclage that you will put, the cerclage is called as McDonald's cerclage. क्या बोलते हैं उस cerclage को? That cerclage is called as McDonald's cerclage. Okay, so write it down. The management of the incompetent cervix is cerclage. Okay, and this cerclage is applied earliest around 12 weeks, and you have to remove this cerclage. By 37 weeks. By 37 weeks. Clear? And the most common cerclage we used is called as McDonald's cerclage. It's called as McDonald's cerclage. Clear to everyone? Okay. And what are the findings of incompetent cervix? There is a funneling of the os, and there is a length less than 25 mm. Okay, so and there is a funneling of an internal os. Okay, now the types of cerclage we have. Okay, now most common cerclage we have the McDonald's cerclage, and this McDonald's cerclage is placed on the vagina. Okay, and followed by that we can also have a Shirodka cerclage. What's wrong with this? Let me check it out. followed by that we can have a Shirodkar cerclage, okay, or we can have abdominal cerclage called as trans-abdominal cerclage, okay. So first, McDonald cerclage mostly we commonly use, we close it like this, okay, we close the cervix, and so that the expulsion of the membranes will not happen, and we will open this, we'll apply this around 12 weeks and will open around 37 weeks, okay. Now sometimes the normal vaginal delivery can happen when a patient is using a McDonald cerclage, but agar transabdominal cerclage hai, then the mode of delivery we go for the cesarean section, then the mode of the delivery we go for is a cesarean section. Okay, now is that clear to everyone? What is a septate uterus? What is a bicornuvate uterus? What is a incompetent cervix? एक कोई भी क्वेश्चन आ सकता है. I will give you a quick recap that these three are the anatomical causes of an abortion. So they are usually present in the second trimester. So septate uterus is the most common Mullerian defect. So the management is going to be the hysteroscopic resection. We resect it hysteroscopically. Okay. Second is called as a bicornuvate uterus. There are two horns due to the incomplete fusion of an Mullerian duct, and then we unify them, making a single cavity is called as unification surgery or a Stressman metroplasty. Followed by that, there can be a short cervix called as incompetent os or the cervical insufficiency, and this cervical insufficiency can also be acquired or congenital. Agar congenital hai, that means there is a weakness of the tissues, and if it is acquired, that can be related due to the surgery of a cervix. Okay, कोई भी सर्जरी हुई है उस वजह से हो सकता है, right? And what is the management for this particular condition? So we are going for a cerclage. The most common cerclage, we are using a McDonald cerclage. We are putting this cerclage on the vagina. Okay, अगर ज़्यादा ही short है तो we go for the modified Shirodkar cerclage, and also we go for the trans-abdominal cerclage. Okay, and what will be the classical presentation of a patient? There will be a painless cervical dilation.